Thank you, everyone, for joining us today. I'm going to give you an overview of hepatitis C in West Virginia with an emphasis on hepatitis C in women of childbearing potential and the potential impact on their infants. So here we go. Okay. Want to start by saying we call this disease hepatitis, but it's completely misnamed because hepatitis C and hepatitis B as well are really systemic infections. And it's just that the liver is their favorite target. That's an important thing to keep in the back of your mind. There are many other um, organ systems and sites in the body that are affected by these viruses. So here is some information about hepatitis C incidence in this country. And on the left, you can see that the number of reported acute hep C infections, which is abbreviated HCV throughout this talk, have really been climbing dramatically. And we know this because acute hepatitis C is a reportable illness at the state and federal level. The, the clinical problem is chronic hepatitis C, and this is not a reportable illness at the federal level. So um, in that the majority of acute infections do become chronic. This is kind of the best way we can estimate that. And then you can see on the right-hand side of the slide that really what we're talking about is young adults, that the majority of these infections, although they're rising in all age groups, are rising most dramatically among people who are 20 to 40 years old. And here we go. And if you think about the epidemiology of hepatitis C, um, and this slide focuses on chronic cases, both by sex and age. This is data from the CDC. You see that there are two peaks. One, as I just showed you, that acute hepatitis C has been rising dramatically in young adults. And then there's a second peak in what we call the baby boom population. And this relates to infections that they acquired decades and decades ago. And I think this is really a fact that's not well known, but around 2006, 2007, the mortality rate of viral hepatitis, specifically hepatitis C, in this country overtook the mortality rate for HIV. And I don't think people are aware of this, but untreated hepatitis C and hepatitis B are, are lethal illnesses. So the most common risk factor for hepatitis C is injection drug use. And this accounts for probably at least 70% of the cases. And can be the case even if somebody only injected a drug one time, and that was many years ago. And that risk is really related to sharing needles and syringes, but also can occur with sharing any of the equipment that's used to prepare the drug and inject the drug. So the water, the cookers, the cotton filters that people use, all can harbor hepatitis C, and hepatitis C can remain viable on these other materials for days to weeks. Then you can see here on this slide, there's a whole list of other things that can also transmit hepatitis C, blood and organ transplants that happened before we could reliably screen organs and blood for the presence of hepatitis C. Non-professional tattoos are probably a second most common cause these days. Um, and then, much less commonly, but important, is that babies born to infected moms. But generally, because this is a blood-borne illness, any environment that's blood rich, like hemodialysis centers, uh, can be sources of hepatitis C infection. So here's data that the CDC presented some years ago, they looked at acute hepatitis C in Central Appalachian youth. These were people 30 years old or younger over the 7-year period from 2006 to 2012. There were almost 1,400 cases, and those were in West Virginia, Virginia, Tennessee, and Kentucky. And this was an almost 350% increase and very much tied to injection of opioids, primarily among whites living in rural and small urban areas. And in this study, injection drug use was acknowledged to be a factor in almost 3/4 of the cases. So what I'm going to show you now in the next few slides are a series of heat maps that we developed for a grant that we submitted at the end of 2015. So it'll end in 2015, but it will give you a good idea about how hepatitis C has been expanding in West Virginia. And you can see the darker the color, the greater the problem. And you can see back in 2012, this was a problem primarily concentrated in the southern coal fields. And here's 2013, 2014, 2015. So you can see over that brief 4-year period, the incidence of acute hepatitis C marched northward in our state. And here's recent data from the Bureau for Public Health from 2023. And this is also a heat map in a different set of colors. And you can see that there's still a heavy concentration of chronic hepatitis C in the southern half of the state, but also you can now see that the march northward has consolidated and is really quite real. And if you look at the maternal hepatitis C prevalence per 1,000 live births in a given county, and this is data from the CDC from several years ago. You probably did not need me to draw this red box around Central Appalachia, but you can see that the area that includes all of West Virginia really has the highest rate of hepatitis C among women having children. And here's another way of looking at that. Again, this is data from the CDC based on state estimates of Hep C among pregnant women. And once again, you probably did not need me to draw that rectangle again around West Virginia at the very top. And you can see we have twice the estimate of Kentucky, which is the next most common state. And back in when we really started understanding what a problem this was in our state, perinatal hepatitis C became a reportable condition in the middle of 2022. And in just that half year, 11 confirmed cases among infants born to women with hepatitis C were confirmed. And given that and we'll go over this in a little more detail further along in this talk, given that the expected estimated rate of mother-to-child transmission of hepatitis C is around 6%, then for 11 confirmed cases to be discovered in half a year means there were an awful lot of women with hepatitis C who were pregnant and giving birth in that year. And here again is data from the Bureau for Public Health that covers the period 2019 to 2025. And this is both gives you acute Hep C case counts and then chronic case counts on the right-hand side. And you can see that the number of cases that are being reported has decreased over this time period. Our epidemiologists at the Department of Health did this through data matching between public health reports of hepatitis C and the vital statistics birth files. So this identified 201 infants with potential perinatal hepatitis C exposure. just in 2023. And here is parallel data for children with hepatitis C over the same time period. And you can see that we are doing a better job of identifying these children, and we can see that in 2025 alone, there were 10 infants with confirmed hepatitis C in our state. So way back in 2020, the CDC published guidelines that recommended universal screening of adults. Everybody, at least once in their lifetime, everybody 18 years of age and older, every woman in every pregnancy, and then more regular screenings for everyone with risk factors, which would, of course, primarily be people who inject drugs. And the issue is how to do this test. And this, I think, has been a source of confusion for a very long time, because the common screening test is antibody to hepatitis C. And you can detect this somewhere between a month to almost 3 months after someone becomes infected. And almost everyone will have antibody by 6 months after infection. But this is not a clinically useful tool, because this really only tells you who's been exposed to hepatitis C, but not whether they currently have hepatitis C, because there are a lucky minority of people who wind up having immune systems that are capable of clearing the hepatitis C. And once you're exposed to hepatitis C, you will be antibody positive for life. But you need a confirmatory nucleic acid test to know that it's active viral replication, that the virus is reproducing itself. And the most common test that we use for this is something called the polymerase chain reaction, or PCR. And this will give you a quantitative result. It'll tell you how much hepatitis C there is in a given volume of blood. And we refer to this as the viral load. And this can be detected as early as 2 to 3 weeks after infection, which means you can see a viral load both in acute disease and chronic disease. And it is this test that is clinically useful. Typically, if you're going to be one of those lucky folks who are able to clear the hepatitis C because you inherited a good immune system from your parents, then this can be positive. You'll have a positive viral load, maybe out to 6 months. But after 6 months, your immune system is taken over and the virus is cleared. And it really is the surveillance, the definition that the CDC uses, that defines chronic hepatitis C as a positive viral load that happens at least 6 months apart. And that helps us distinguish acute from chronic infection. So how do you order the right test? And this is how you do it. You order something called hepatitis C antibody with reflex to RNA PCR. And if this is not a lab that you can order, then ask your IT specialist to update your electronic medical record so that this is the way you can order it. And what this does is that if the lab detects antibody, it will automatically proceed to check the RNA PCR. In other words, it will automatically move to the viral load step. And this means you don't have to call the patient back for another blood test for that the confirmatory lab test. And because we lose a lot of people between blood draw 1 and blood draw 2, so this just makes it more efficient for both you as the clinician and for the patient that just have a single blood draw that will give you the answer. And actually, about 2 years ago, the FDA approved a point of care RNA test. So you can actually, through a finger stick amount of blood, can get an answer within an hour. And hopefully, as this test becomes more readily available, we will be able to do something like test a patient and offer them therapy on the same day, something that we call test and treat. So it's important for patients to understand that chronic hepatitis C is a disease of decades, not days. Um, this is a disease that can progress to cirrhosis over a period of 25 to 30 years in patients who only have hepatitis C. If they also have HIV, which is, of course, also transmitted from injection drug use, then that time period to the development of cirrhosis is halved and can happen in about 15 years. But even in that situation where someone has both hepatitis C and HIV, we're talking about a long period. So it's a way of reassuring people that, nothing is going to happen tomorrow. And it's important for your patients to understand how this virus is transmitted. There is a very low rate for transmission to heterosexual sex partners. It's about 1% per year for people who have routine heterosexual sex. That rate is much higher from men who have sex with men, especially men who also have HIV. And you avoid giving your hepatitis C to someone else by avoiding sharing personal items that could have just minute amounts of blood that you can't even see, like toothbrushes or razors. And people with hepatitis C, of course, should use bandages to cover anything that could leak um, serum or frank blood. And people with hepatitis C should not donate blood or semen or organs unless they're part of some special program. And it's also important to reassure people that you can't get hepatitis C through ordinary human contact. You can't get it from sneezing or hugging or holding hands or kissing or sharing eating utensils or through food or water. It's really primarily direct contact with blood, um, and to a much, much, much smaller degree, sexual contact. The important thing to do when you find that someone has chronic hepatitis C is to look for the co-infections that, the other diseases that travel with hepatitis and vaccinate or treat them as needed. So you should look for hepatitis A and hepatitis B in all of these patients and vaccinate them if they're not currently protected. You should, of course, look for HIV because these are individuals who will need immediate treatment to control the HIV, which we can do a wonderful job of controlling these days, although we cannot cure it as we can hepatitis C. And you should look for sexually transmitted infections, especially syphilis, as we are now seeing a significant increase in syphilis across West Virginia, including babies who've been born with congenital syphilis. So since sex and drugs are the way people get um, uh, these infections, these are the things you need to look for. Patients should be advised to avoid alcohol because alcohol can accelerate liver damage. And people who have what we call now metabolic dysfunction associated steatotic liver disease, which is a real mouthful, but really means that people who have diabetes or have morbid obesity and have, as a result, the storage of too much fat in the liver, which is what steatotic liver disease is, also accelerates the fibrosis, the damage to the liver that hepatitis C causes. And these problems can be treated as needed, optimal control of hepatitis, loss of weight. GLP-1 drugs have also been shown to be helpful in this circumstance. And also keep in mind that the risk factor of substance use disorder, which is really what we're dealing with here in West Virginia, this is what kills most people, right? Through overdose uh, and associated problems like endocarditis. So, these are the things that you should be concerned about as a clinician and be advising your patients. So we do have these amazing drugs now. They're called DAAs, which stands for direct-acting antiviral. And why do they have this weird name? Because before we had these drugs that were very specific for hepatitis C, we used to use interferon, which has some effect on hepatitis C, but a kind of indirect. And that's why these new drugs are called direct acting. And we use them as combinations of two or more of these drugs. Typically, they'll either be packaged together in one pill or packaged as two or three separate pills, but packaged together so that they can be taken at the same time. And we can cure hepatitis C in as few as 8 to 12 weeks in almost everybody. That is amazing. And this has only been available for about 10 years. So we had the first of these combination drugs in around 2016. And we can achieve a cure in almost everyone, 95 to 99%. And the technical term for this is a sustained virologic response, or abbreviated SVR. And we call it an SVR12 because historically we looked for evidence of the clearing of the hepatitis C virus from blood 12 weeks after the people took the last pill. And this is true that we can have this amazing clinical response, even in what used to be thought of as special populations, people that were hard to treat, like people who inject drugs and people with HIV. They turn out to be no harder to cure than anybody else. And luckily for us and our patients, the side effects are negligible. They're easily manageable. They're primarily things like headache and nausea. And usually people develop tachyphylaxis to that within a week. And but if people do have problems with headaches and nausea, you can deal with that by giving people medication for that. It is rarely treatment limiting. So amazing, powerful drugs, almost no side effects, and a cure in 8 to 12 weeks, which is truly transformative. We do have this risk of mother-to-child transmission. Now, women who are antibody positive, but viral load negative, right? The RNA PCR is negative, have absolutely no risk of transmitting to their infants because these are women who are, if they're antibody positive and PCR negative, these are women who have had the great good fortune to clear the virus on their own, and therefore there is nothing there to transmit to an infant, right? Once you're antibody positive, you're going to be antibody positive for life. And the overall risk is close to 6%. Now, this is based on 17 different studies, although I should caution you that the studies had relatively small numbers. So it's the best estimate we have, but it may not turn out to be 100% accurate. But what we do know is that the size of the mother's viral load correlates pretty clearly with the risk of transmitting to their newborn. So if you have a relatively small viral load, so 3 logs is, a viral load that's over 1,000, we really don't see transmission. And we see a transmission rate of about 11% if it's more than 6 logs. So that's a viral load of about 1 million. And we also see a greater risk of transmission with genotype 1. And if the mother has the misfortune of having both hepatitis C and HIV, then the presence of the HIV doubles the risk to about 11%. Some of the physical risk factors for mother-to-child transmission are prolonged rupture of membranes, okay, during the birth process. This is more than 6 hours, or any kind of obstetric procedure or intrapartum event that could expose the newborn to hepatitis C through infected maternal blood. So internal fetal monitoring is a risk, or vaginal and perineal lacerations are a risk. And then, of course, maternal injection drug use is a risk. However, mode of delivery has no association with increased risk of mother-to-child transmission. So it doesn't matter whether the baby is delivered vaginally or by C-section. And breastfeeding, and this is so these facts are different from what happens with HIV. Breastfeeding also does not transmit hepatitis C unless for some reason there is blood contamination, like if the mother's nipples are so sore and cracked that they bleed. And in that case, you just tell the mom to stop nursing until that heals. And that's because there's no virus in breast milk. It's just in the blood. So how do we manage women who have um, hepatitis C uh, and, could become pregnant? Well, the ideal thing would be to cure them, right? To clear the hepatitis C before they become pregnant. But a lot of people can become pregnant, without sort of a lot of fore, forethought or planning. And although that's ideal, it's probably not the situation that we see most commonly. So when you are counseling a pregnant woman who has chronic hepatitis C, they should understand the potential risk for transmission to the baby, which, as I said, is about 6%. They really need to understand that both they and themselves need ongoing follow-up and testing after they give birth, because about 10% of the women who have chronic hepatitis C are able to spontaneously clear it after childbirth. So, there's another lucky 10%, and they need to know that. And then, of course, the infant needs to be followed. And we'll get into that in detail in a little bit. During the pregnancy, um, all pregnant women with hepatitis C need to be treated as they need to for their individual obstetric risk. We really don't have a currently approved intervention to reduce mother-to-child transmission. And so hepatitis C viral loads and routine liver function tests should be obtained at the beginning of prenatal care, and so that you can assess the degree of risk. As I said, viral loads have a lot to do with whether a mom can transmit hepatitis to her infant. And you want to have an understanding of, if this is a woman who already has a fair degree of liver damage. Very especially important if you're a woman with hep C is pregnant and develops itching or jaundice, then you really need to be concerned about something called the intrahepatic cholestasis of pregnancy. And you monitor that with looking at the liver transaminases and serum bile acids, because this is not a good complication of pregnancy. And it's pretty unusual given how recent our drug epidemic is, but not impossible for a woman of childbearing age to have cirrhosis. But as I said, since it typically takes 20 to 30 years to develop cirrhosis, even if you get infected at age 20, the likelihood that you're going to have a baby at 45 or 50 isn't very high. So we really have not had to deal with that very much here in West Virginia. But let me show you an important study that was done looking at both the infants and the outcomes of the pregnancies and the obstetrical issues, comparing women who had hepatitis C and women who did not have hepatitis C during pregnancy. And I know there's a lot of numbers on this slide, and I put some of the ones that I think are most dramatic in red, but you can see in that right-hand column that everything is highly statistically significant. So women who are Medicaid insured, uh, and married women, that's a social factor. Um, Non-Hispanic whites are the women at highest risk, and you can see that in the right-hand side of the slide. That's the blue curve for non-Hispanic whites, and you can see how dramatically over the period of this study, uh, the prevalence of hepatitis C increased among white women. And if you look at prenatal factors, smoking is a significant risk. We go to the next slide. Now let's look at the obstetrical and neonatal outcomes of these pregnancies. So again, boy, everything is highly statistically significant. But you can see that there's that preterm birth, whether it's less than 37 weeks or less than 34 weeks or less than 28 weeks, is all significantly associated with hepatitis C, as is low birth weight and small for gestational age. And then if you look at the infant outcomes, is a statistical correlation with admission to the neonatal intensive care unit. So these are women whose both obstetrical course and the outcome for the infant really carries significant risk. Oh, I have two versions of this slide. Okay. So you may all be well familiar with the West Virginia birth score, which was amended several years ago to include the evidence of maternal hepatitis C. And the point of doing this was to be able to ensure that the healthcare provider for the child was aware of a risk exposure, because that's being able to follow that in the HIPAA era where the mother's health records and the infant's health records are not associated. It's really important for the caregiver for the infant to know that they've been potentially exposed and can be followed appropriately. So now let's move to that. We've mentioned that. Let's talk about how do you assess an infant for transmission, for mother-to-child transmission of hepatitis C. And this is a recent change and very, very important. We used to have to wait till the baby was at least 18 months of age, because then we would go through that same series that we did with adults, where we would get a Hep C antibody, and then if that were positive, you'd move to then getting a hepatitis C viral load. And you had to wait till 18 months because that's when the maternal antibodies that are transmitted at birth to the infant are all gone. But now we have really solid data that we can do a single nucleic acid test, so an RNA PCR for an infant as early as 2 to 6 months of age. And if it's positive, these are children who may go on to develop chronic hepatitis C. It's very sensitive, it's very specific, and what's really so much better than having to wait till at least 18 months of age is that we can identify the infants who need to be followed carefully for curative therapy on their own and prevent loss to follow-up. And this is something we can determine quite early in life, because, if you have to wait till after 18 months of age, these are children who can get lost in the shuffle. And if you have an infant that has detectable viral load, then they should be managed ideally in consultation with a clinician who's got expertise in pediatric hepatitis C management. And you're going to hear from the world expert, Dr. William Balistreri, in the next talk in this series about how to care for infants and children with hepatitis C. And nobody knows that better than Dr. Balistreri. If the infant has an undetectable viral load, then that's it. You don't have to go any further, unless there's some other reason to provide follow-up for liver disease, that baby is going to be okay. So here's the big issue now. Should we treat women who have chronic hepatitis C during their pregnancy? And there are arguments on both sides. We do not actually have um, any drugs that are approved by the FDA for use in pregnancy. So, I will state that right up front. But here are some of the arguments in favor of treatment. And if we are going to treat during pregnancy, we would wait until uh, into the second trimester. So after all of the organs have formed and there is no exposure of the developing fetus to drugs that might affect organ development. But in favor of treating during pregnancy is reducing postpartum loss, because here's a time when these are women who are engaged in prenatal care. They're covered by insurance. Um, so you don't have to worry that they'll be subsequently lost to follow-up, because you're probably well aware, as I am, of the stigma that accrues to having substance use disorder, and the stigma that also follows having chronic hepatitis C. And these are typically people who don't love to hang around medical care facilities. So, they often get lost to follow-up after they deliver. It is, of course, possible that clearing the virus during the pregnancy might decrease mother-to-child transmission, although we have no studies that prove that. We do know that babies who are infected vertically from mother to child will develop cirrhosis at an earlier age than children who acquire infection in other ways. And from an important study from the UK, they were also at risk of acquiring hepatocellular carcinoma, liver cancer, which is one of the, in addition to cirrhosis, one of the very sad end stage outcomes of chronic hepatitis C. And lastly, surveys indicate that most women with Hep C would be interested in Hep C treatment during pregnancy if it would decrease mother-to-child transmission, although that's not something that we can promise them. The argument against treatment is that currently we have limited data on treatment in pregnancy. There is an ongoing study of sofosbuvir and velpatasvir, which the trade name is Epclusa, that starts in the 26th week of pregnancy, so deep into the second trimester, that's ongoing in the United States and Canada. And in fact, one of the study sites is at Marshall in West Virginia. And so far, the study has not completed, but so far the interim data look very promising in terms of lack of toxicity to both the mother and the infant, and good outcomes. We don't know, as I mentioned earlier, that this will actually prevent vertical transmission. It seems logical. We certainly do this for HIV, and it works very, very well. And there are similar drug classes, but we don't know that. We don't know about treating after birth, but in breastfeeding women, although the virus is not transmitted through breastfeeding. And of course, we don't have data about cost effectiveness. So there's data on both sides of the question here. But because these drugs are so well tolerated, and because they belong to parallel the same kinds of drug classes that we've been using to prevent HIV since the early 90s, the stance on treatment during pregnancy has been shifting. So as I mentioned earlier, ideally, we should cure women before they become pregnant. But if we know that they have chronic hepatitis C, and that's discovered during pregnancy, it is reasonable to have a discussion with that patient. And the new guidance on this, and this comes from the guidelines that are published by AASLD, which stands for the American Association for the Study of Liver Disease, And it's a combined set of guidelines made with the IDSA, the Infectious Disease Society of America. And these guidelines for the last 6 years have said that you can consider treatment in the later stages of pregnancy on a case-by-case basis after a clear discussion about potential risks and benefits with your patients. And there's no question that there are clinicians, both obstetricians, hepatologists, and infectious disease docs who are doing this. So we have this wonderful medicine. It's incredibly well tolerated. It cures almost everybody, and not enough people are getting it. So here's data from the CDC from a couple of years ago, and this talks about when they say timely hepatitis C treatment, they mean within a year of diagnosis. Less than a quarter of Medicaid-insured people were receiving treatment. Only a few more percent of people insured by Medicare were receiving treatment, and even people with private insurance, only a little more than a third were receiving treatment. And that, folks, that's not acceptable, because we really do have these terrific drugs that are not dangerous to take, and curing a disease that could go on to kill you from extensive liver damage, which is cirrhosis, and liver cancer. That just needs to be done. And we have to ask ourselves, well, what are the problems? What are the obstacles that get in the way? And I'll give you my take on this. I think a lot of clinicians who completed their training before about 10 years ago, when these combinations became available, really don't know that hepatitis C can be cured so easily and with minimal toxicity, because they were already finished school and finished their training. And the experience that they had of hepatitis C was really affected by the very limited success and huge toxicity of the interferon era. And in that era, hepatitis C was managed by hepatologists initially, and then a little later on by infectious disease docs. As I mentioned already, there's stigma around injection drug use and around hepatitis C. There is this ongoing confusion about how to interpret the Hep C blood tests. I can't tell you how many patients have come to see me as an infectious disease expert who've been told they have chronic hepatitis C because they have a positive antibody test, but no one went on to look for a nucleic acid test, a PCR test. And I think a lot of people just don't feel confident about diagnosing and treating what to them is a new problem that they're concerned about might be very complex. And there's not easy access to expert guidance. There are, I think, these days 3 hepatologists in the state of West Virginia. There probably are not just about 24 infectious disease docs. And all of these experts are in our cities. They're not out in the community. So here's one way that I'm going to talk to you about 2 different programs very briefly that have been developed here in West Virginia to remedy this problem. The first is WVHAMP, West Virginia Hepatitis Academic Mentoring Partnership. This is a free online HIPAA-compliant educational and consultation program. And this empowers both primary care and substance use treatment providers to screen, diagnose, manage, and cure Hep C in the community. And we do this through case-based guidance from experts. Everybody gets free continuing education for participating, and the trainings are held quarterly, take a whole day, and this is the way to register. And I'll show you some of the data. We've been doing this since March of 2020. We actually had the first training the week before West Virginia shut down for COVID. So we've been doing this for 6 years, and we have responded to 2,400 consultations submitted by 103 primary care clinicians. Referrals, the proportion that are referrals keeps climbing, which means that the folks who've been trained really have become recognized as a resource in their communities. We have 935 patients who have finished therapy and reached that time point for determining cure. Remember, that's SVR 12. That means 12 weeks after the last pill. And we have an almost 98% cure rate. And I think this shows that with guidance and support, clinicians who have never previously diagnosed or treated Hep C can do just as well as we, the experts, can. And here's our second program that I'm also a part of. This is the Project ECHO at the West Virginia Clinical Translational Science Institute. This is also a free online program that is held twice a month for an hour. There have been over 600 de-identified cases that have been presented and discussed since the start of ECHO, which I think maybe has been going on for at least 8 years, maybe 9. The hour usually includes a 10 to 15-minute didactic portion and then presentation of cases with a group of experts. Also provides free continuing education credit. And again, you can register online at this link. So what we need to understand is that treatment as prevention, which is a concept that we first developed for HIV, but is just as pertinent to hepatitis C, especially among people who inject drugs, is a real thing. Because the population that's actively transmitting virus, if you can cure that infection for Hep C or control it for HIV, then you reduce new infections. And over time, the number of people in the community who get these infections decreases. And this continues to bring us closer to elimination, which is both a global, a U.S. Public Health Service, and a West Virginia Department of Public Health goal. And in fact, we have a plan that is in the process of being updated for the next 5-year cycle. And we here in West Virginia have combined HIV and hepatitis together. Not every state does in their elimination plan because they're so clearly both associated with injection drug use here. And the goals of this plan are, of course, aligned with both the global and the nationwide goals. And I want to end with this important reminder. This is what we need to do for all women who present for prenatal care. They need to be screened for hepatitis B, hepatitis C, HIV, and STIs, especially syphilis, for which we are really seeing a huge increase in West Virginia. And I want to thank you for your attention. And let's move to whatever questions have come up. Chantry, you want to